Hello everybody. Over the next 20 minutes we will discuss optimal imaging strategies for advancing prostate cancer, taking as the basis of our discussion the ASCO guidelines. Here are my disclosures. All of us should be aware that prostate cancer is categorized by multiple disease states, which is determined by tumor characteristics, the radiographic extent of the disease, mostly on bone scans and CT scans, and the underlying testosterone levels. We're also aware that there's been major progress not only in systemic therapies but also surgery and radiotherapy, and there is the evolving role of theranostic biomarkers, all of which are changing survival times. However, there continue to be multiple unique imaging challenges as the disease advances. So, for example, we're all aware of a rising PSA without metastases being seen on conventional imaging. We are all aware that there are difficulties in monitoring patients with bone disease due to limitations of conventional imaging. However, there is a great interest in identifying better imaging strategies to inform on the optimal imaging of patients with advancing prostate cancer. However, up to now, modern imaging has focused on diagnostic performance, and better evidence on care pathway impacts are needed. So here are the prostate cancer clinical states that many of you will be aware of. You can see on the left-hand side, we've got localized disease. Here are more advancing states, which can either be hormone sensitive with normal testosterone levels or castration resistant with low testosterone levels. And the metastatic state currently is defined by bone scans and CT scans. Remember that next generation imaging detects micrometastatic disease and microprogressive disease. There certainly is a need for better evidence for the management impacts of next generation imaging, both in the detection state and for therapy assessments. So next generation imaging has particular advantages for looking at bone disease, and because it improves disease detection sensitivity, at initial staging this is micrometastatic disease, and during therapy this is microprogressive disease. And the early detection of disease can lead to stage migration as well as lead time biases, which we will discuss next. On the top right, you can see that the detection sensitivity for the PET tracers and whole body MRI are better than the bone scan. And this can lead to stage migration effects. So if you have a patient with locally advanced M0 disease, if you do next generation imaging, they could have oligometastatic disease, or if you think they have oligometastatic disease, they could have polymetastatic disease. And this ability to see disease at a smaller volume and then institute therapy can lead to lead time bias, particularly if the treatment instituted does not cause an overall increase in survival. There are also effects in the response assessment setting. So conventionally, using bone scans and CT scans, we divide patients doing therapy monitoring as either progressing or non-progressing. Next generation imaging allows you to split this category into patients who are stable, patients who are responding, or patients who are progressing. And progression categories can also be subdivided into microprogression, that's to say response assessment category 4, or major progression. Now, because you can detect microprogression at an earlier level, if you institute the treatment that you were going to institute, but it did not increase overall survival, then that means that this time is a lead time bias. However, if you can respond to the earlier detection of smaller volumes of disease, for example with metastasis-directed therapies, and then institute the therapy that you were going to, then it is possible to push this out to get an overall increase in survival. So better staging and response assessment with novel imaging should better inform on the disease state to personalize therapy and decision making. so that you can maximize the benefit for patients and also minimize undertreatments and reduce or even prevent overtreatments. However, currently next generation imaging is incompletely validated for this purpose, which could have two consequences. Firstly, patient may be subjected to treatment intensifications that does not improve overall outcome and may in fact increase morbidity, toxicity and costs. On the other hand, withholding potentially beneficial therapies in the hope of sparing unnecessary toxicity may indeed lead to the patient detriment, resulting in undertreatments, increased odds of cancer morbidity and mortality. So we do need prospective studies to validate the management impacts of novel imaging, including considerations of cancer-related outcomes, but also toxicity and costs. So here are the advanced prostate cancer states. And for all of these states, the ASCO guidelines that imaging should be performed according to the clinical scenario. One or more modalities should be undertaken, either conventional imaging and or next generation imaging, depending on the scenarios. It is recommended when choosing an imaging modality that the scenarios take into consideration whether or not the imaging modality will guide treatment or change treatment decisions. Explicitly, they state that when treatment or prognosis will not be changed, then additional next generation imaging should not be offered. So let's start our discussion by talking about high risk locally advanced prostate cancer, which may or may not be metastatic. So here's a patient with Gleason 9 cancer, both at the base and in the midglandular region, which is PSMA positive in the midglandular region. You'll notice how at the base of the gland, the lesion is PSMA negative. And you'll see there's a lymph node metastasis in the left internal iliac region, which is also PSMA negative. So how common is it for lymph nodes to be PSMA negative when we know that the primary tumor is PSMA positive? Well, it turns out it's not that unusual. So if you look at the sensitivity of PSMA-PET for being able to predict the presence of lymph node metastases in surgical series, you'll see that the per patient sensitivity for nodal disease is somewhere between 40 and 60%. Indeed, it looks as though the larger the cohort size, the less is the sensitivity. But the real question is are these smaller missed lymph nodes clinically important? To answer that question, let's look at this randomized study where men with N0 locally advanced prostate cancer were given radiotherapy. Patients were either treated with standard radiotherapy to the prostate or an escalated therapy to the prostate and to pelvic sidewall lymph nodes. You'll notice that 82% of these men were called node negative on the basis of the PSMA-PET study. If you look at important survival endpoints such as disease-free survival or metastasis-free survival over the next months and years, you'll notice how patients who had prostate radiotherapy alone tended to relapse. Those patients who received prostate and pelvic sidewall radiotherapy, they tended to have a better survival. This indicates that microscopic metastatic disease that is negative on a PSMA-PET CT scan is clinically important, determining long-term outcomes. However, the PRO-PSMA study compared PSMA-PET CT scans with bone scans and CT scans in people with high-risk localized disease going to surgery. Clearly, the PSMA-PET CT scans are better than bone scans and CT scans, so you can see the accuracy here, and you can see that there were management impacts. So yes, PSMA-PET CT is more accurate, it is more specific, but it does miss microscopic nodal metastases, which means you can't use a negative PSMA-PET CT to limit intended nodal therapies. So what do the ASCO guidelines say? The ASCO guidelines first recommend you perform conventional imaging, and then you can think about doing next generation imaging when the conventional imaging is either negative or equivocal. So when conventional imaging is suspicious or equivocal, next generation imaging may be offered for the clarification of equivocal findings or may find additional sites of disease which could potentially alter management, although prospective data are limited. Next, let us talk about biochemical recurrence and biochemical persistence. So here's a man who had a prostatectomy for this large left apical tumor, and after prostatectomy his PSA was persistently raised, and we can see that the PSMA-PET CT scan identifies a right internal iliac lymph node. What does the ASCO guideline say about this circumstance? Both biochemical recurrence and biochemical persistence are indicative of potentially undetected residual local, loco-regional, or microscopic disease, and imaging options are not distinct or different between these scenarios. The goal of therapy, therefore, is to use salvage therapies to be able to rescue these patients. For men who are not candidates to receive salvage therapies, next generation imaging should not be offered, as there is very little evidence that next generation imaging will alter subsequent treatments or prognosis. For men in whom salvage therapy is being contemplated, next generation should be offered, and it recommends PSMA PET CT where available, or choline PET CT or fluciclovine PET CT, and may alter management. Another question that we should ask ourselves is, should you perform systemic imaging before you do local imaging, or should it be the other way around? The ASCO guidelines suggest that systemic imaging should be performed first using a next generation imaging technology, and in those patients with biochemical recurrence following previous radiotherapy, then a multiparametric prostate MRI with prostate biopsy should be considered. Regarding metastatic hormone-sensitive prostate cancer, we have to remember they can occur at the time of initial presentation, synchronous metastatic disease, or sometime afterwards, metachronous oligometastatic disease, and it can be oligometastatic or polymetastatic. Regardless, it is bone scans and CT scans that are used to stratify patients with metastatic hormone-sensitive prostate cancer using either the latitude definition or the charted definition. The charted definition uses imaging alone. The latitude definition uses imaging plus Gleason score. Here's an 82-year-old man who appears to have low volume, low risk metachronous polymetastatic disease based on conventional imaging with just a few bone metastases. You can see that on next generation imaging he has high volume, high risk disease with a spinal cord compression. So he went from therapies that would be appropriate for low volume, low risk disease to high volume, high risk disease, and he received ADT plus docetaxel. This is the only indication for the next generation imaging in hormone sensitive prostate cancer that is referred to in the ASCO guidelines. It says that you can use next generation imaging when the conventional imaging is positive to clarify the burden of disease and to alter therapy plans, and indeed it only refers to shifting patients from oligometastatic disease to polymetastatic disease because it acknowledges that the therapies would be different. However, it does not distinguish between de novo or synchronous metastatic disease and metachronous disease, although their prognosis is different. For oligometastatic disease, it makes no recommendations on the number of the locations for deposits for oligometastatic disease. It makes no recommendations on the use of next generation imaging to guide focal therapies. It makes no recommendations on the use of next generation imaging to distinguish high risk, high volume disease from low risk, low volume disease, and in fact it suggests the use of the APCC 2017 guidelines for therapy monitoring of metastatic hormone sensitive prostate cancer. So, is this man with oligometastatic disease suitable for CyberKnife radiotherapy, given that the single deposit is only detected by conventional imaging, bone scans, CT scans, and the morphological MRI. If we look at the Oriole study, we can see that patients were treated with CyberKnife radiotherapy for oligometastatic disease on the basis of conventional imaging alone, and we see a better disease-free survival for patients with CyberKnife radiotherapy compared to patients who were on observation, suggesting that the strategy is valid. However, 45% of these men had PSMA positive lesions that were left untreated. So if we look at these men, we'll notice that CyberKnife radiotherapy had the greatest benefit when there were no untreated lesions left behind on the PSMA-PET CT scans. Indeed, men who had CyberKnife radiotherapy to all PSMA visible lesions had the lowest risk of developing new metastases in the next 6 months. For castration-resistant prostate cancer, let's first talk about non-metastatic CRPC. For men with non-metastatic CRPC on conventional imaging, next generation can be offered only if a change in clinical care is contemplated, stating that the detection capability of next generation imaging in this setting and the impact on management are somewhat limited. But that was before this recent analysis, which looked at high risk non-metastatic castration-resistant prostate cancer and showed that there was a high positivity rate for PSMA-PET CT, with about 50% of men having metastatic disease that was detectable, and a few of these men, in fact, had oligometastatic disease. The ability of PSMA-PET CT scans to detect microscopic metastatic disease in about half the patients with M0 CRPC may be able to identify a higher risk subgroup, and therefore opens up an option for metastasis-directed therapies for oligometastatic disease, although we don't know what the impact on overall survival quality of life would be. However, we have to acknowledge that current treatment approvals for non-metastatic prostate cancer are based solely on conventional imaging, so treatment decisions should not be based on PSMA PET CT findings at this time. Regarding therapy monitoring of metastatic CRPC, the guidelines continue to recommend the use of clinical assessments, bone scans and CT scans, and PSA scans. The guidelines do say, however, that PSA progression should not be used solely to change therapy, and that conventional imaging should be done when PSA seems to be progressing, so that you can have serial assessments going forward to look for the development of radiographic progression. The guidelines also say that the role of next generation imaging in therapy monitoring is unclear. However, it does say when there is a high clinical suspicion of progression despite a non-changing conventional imaging, next generation imaging can be contemplated, particularly in trial settings. However, if next generation has already been performed at baseline and to facilitate future comparisons, then it may be undertaken to see what the pace of disease is. This opens the door a little bit to the introduction of next generation imaging for therapy monitoring. You'll remember that I said previously that for metastatic hormone-sensitive prostate cancer, the ASCO guidelines recommended the use of the APCC guidelines. The APCC guidelines suggest bone scans and CT scans in patients with metastatic hormone-sensitive prostate cancer at baseline at maximal response, and to assess tumor load at tumor resistance based on CT scans and on clinical failure. However, the APCC guideline does say that bone scans and CT scans should be performed more regularly in castration-resistant prostate cancer. The major change are these two items here. Next generation imaging may play a role if already performed at baseline to facilitate future comparisons to see what the extent of disease progression is, and when a change in clinical care is contemplated on the basis of suspected clinical progression despite unchanging conventional imaging, then next generation imaging could be offered. So here's an example of one such patient. This man has metastatic castration-resistant prostate cancer. He's being treated with pembrolizumab and olaparib. You can see that we were blinded to his PSA. On multiple subsequent occasions, you can see that he has a stable CT scans, yet he was clinically deteriorating, was taken off the clinical trial, and you can see how the whole body MRI shows marked disease progression, and when we unblinded the PSA, you can see that he was clearly progressing. Okay, let's do a final run through of the indications. So in high risk localized disease and high risk locally advanced disease, next generation imaging can be used when conventional imaging is negative or suspicious and the clinical suspicion is high. For biochemical recurrence, next generation imaging is for negative or equivocal conventional imaging in high risk biochemical recurrence patients who are most likely to benefit from salvage therapy. For synchronous or metachronous metastatic disease, that is hormone sensitive, next generation imaging can be used when disease volume and distribution will affect prognosis and therapy choices. In this setting, it appears to be most useful for metachronous oligometastatic disease detection and for therapy planning. For non-metastatic prostate cancer, next generation imaging can be used to detect oligometastasis and direct metastasis-directed therapies that would postpone the use of systemic therapies, although the data is limited. And finally, for castration-resistant prostate cancer, we know there's a discordance between clinical and PSA and radiographic progression, which often leads to patients with poorer outcomes, and regular imaging, either with conventional imaging or with next generation imaging, is required.